Thank you so much, Dr. Glover. Thank you to Dr. Morris and the Knight ADRC for having me here. And thanks to all of you for listening to me for a few minutes, and also for bearing with me while I make sure I can operate the technology here. Surprisingly, I cannot. No, just kidding, that's not surprising at all. Okay, so Crystal hinted at it. I'm not going to try to go back even. What I'm going to be talking about today, though, is some new additions to the uniform data set utilized by all of our, can I call them ADCs? Should I be calling them ADRCs? I'll probably switch back and forth here. But all of our centers talk about some new additions to that, but also try to justify a bit for all of you why we think we needed to add this new module on social determinants of health. Where we were at before, we had harmonizable social determinants data, what we're doing to address that as a gap, and then really importantly, and I might even have to speed through some stuff to get there, what we should probably do next as centers and as investigators in those centers. So I'm going to start, of course, with just this base definition of social determinants of health that almost everybody has heard at least once before, right? Social determinants of health, as we talk about them now, are the conditions in which people are born, they grow, they learn, they work, they live, and they age, right? This is a life-spanning, cross-domain set of risk and protective exposures in various socio-environmental domains. There's actually a definition, though, that for today I think is even more important for all of us as dementia researchers, for persons who care about dementia work moving forward in an equitable way. That is that these social determinants are the non-medical factors that influence, and public health data actually would tell us that they influence 40 to 80% of health outcomes. ADRD has, the dementia field, has really started talking about these in any really big field-wide way relatively recently, but certainly brain health, memory health, cognitive aging is not somehow accepted from these other health outcomes that are driven by social roots. So far, our uniform data set, and in fact, most centers, though, have not collected any data about these social conditions that our participants are living their lives in, right? We've been really focused on collecting incredibly rich biomedical data and also a smattering of probably what I would call health behavior data, looking at brain healthy behaviors that we think might prevent or increase risk for dementia and for brain aging. The problem here, and I'm going to focus here on racial disparities in my example. We're going to talk about other axes of minoritization in some of the upcoming talks, but as many of you know, race is where a lot of the work has happened, and that's been happening since probably over 2 decades ago. I'm thinking of that initial YCAP paper. We started talking about the fact that dementia and dementia risk were disproportionately and probably unjustly impacting some populations more than others, right? So since then, we've been trying to figure out what are the factors that are driving these disparities that we see, so that ideally we can address and mitigate them. Social determinants work in this area, I want to emphasize, is not new, right? Dr. Jennifer Manley and her team, Dr. Vanetta Dotson and her team, these scientists were thinking about what goes in this huge blank space between minoritized race and these biomedical factors, vascular risk, brain health. And what they were doing, they weren't even thinking about social determinants of health as this phrase or this terminology that we've relied on now. They were thinking about historical and contemporary context that produces health disparities that disproportionately impact some populations. And what they found, of course, when they actually considered the social contexts that people were living in, that their participants were living in, they were able to come up with research questions and design studies that have really robustly demonstrated that there are variables like education quality and education quantity, also wealth, that are able to explain racial disparities where all of the behavioral and the biomedical variables that we can put in the world have not been able to explain those. There's also, much more recently, a lot of interest both inside and outside of our centers in terms of, as this meeting is so focused on, looking at underrepresentation, disparities in inclusion in terms of participation, retention, eligibility, experiences with research. And again, this work isn't new. And certainly our ADCs have done an okay job of connecting minoritization to differences in people's ability to participate in and to stay in our studies. But we don't have the data that people, again, for years have been telling us that we need to actually explain these relationships and change something. So Drs. Dilworth Anderson, Dr. Wilkins, who you heard earlier today, Dr. Hill from last night, we have seen that there is context that drives this, and we don't have any of it. We've got this vacuum of mechanism, and what mechanism is not some academic exercise. It's really revealing kind of a nexus of intervention points, right, that we need to be considering. Currently, we don't have any of that in most of our ADCs. I want to make clear that there are obvious exceptions for some centers. So to move, well, I just revealed my big slide here. So, man, all right. Was there ever a direct line there? There it is. So we need to add context in order to reveal all of these complex mechanisms that, if we understand them, are going to identify ways in which we can build better social, policy-level interventions, better center-level interventions, design better, more adequate, more beneficial, and more inclusive clinical interventions as well, if we want to actually address some of the population-level inequities that we are seeing, right? And to do that, the first thing, obviously, that I think we need to do here is to remove this direct connection between minoritized race, in this example, and brain health, which basically is establishing race as a risk factor, which doesn't make sense. Take that out and attach race to what it really embodies, which is racism. And that is, in this case, the inequitable distribution of resources, opportunities, and risk exposures across risk domains and across time, across the life course, right? And what I mean by systematized there is that at a population level, not necessarily at an individual level, but at a population level, minoritization exposes communities to systematized risk across all of these domains. In the meantime, of course, and also invisible to us, if we're not measuring it, if we're not thinking about it, if we're not asking about it, is the way that in the absence of institutional resources that have been denied, community-based assets and strengths, whereas my colleague, Dr. Gina Green-Harris, who always talks about this, assets and strengths that are in existence, that are already helping people, they are also obscured, right? So the truth is that all of these exposures are upstream of the things that we are most focused on, like health behaviors, and even recruitment and retention, right? So just to kind of describe what I mean, I tend to focus on adversity and stress as an exposure, as a pathway leading to cognitive aging and to cognitive health disparities. Stress is downstream of many exposures that we might call social determinants of health, or we could just call them the context in which people are living in. Financial hardship, health shocks that are occurring not just to individuals, but within families and communities and neighborhoods, inequities in access to resources. All of these are creating chronically stressful conditions that people are living in, and meantime, those chronically stressful conditions are also upstream of other key factors, right? If the daily challenges that you're facing have a big impact on your ability to engage in physical activity that researchers and your doctors may be recommending to you, to really rigorously manage your hypertension or your diabetes or that of your loved one, to attend a clinical visit, to attend a study visit. Everything that we're going through in our daily life, from the advantage or disadvantage in our neighborhood, to our insurance coverage, to our transportation access. These things are really driving our ability to modify whatever behaviors we're engaging in. So this is why I was so excited, that whole vacuum that currently exists versus what could be there and the potential there, when I heard that the UDS4 was really going to be trying to focus in on collecting many more of these data. There was an early determination to collect some new data on the demographics form. Probably many of your ADRCs actually got a survey about this. Dr. Stites is going to talk, Dr. Flatt did earlier, about the really important sexual orientation and gender identity questions that have been added. Somehow I covered at the bullet point, but we're also offering a lot more flexibility in how individuals are able to define their race and ethnicity. Everyone is going to have neighborhood level disadvantage calculated using the area deprivation index. There are also going to be some really basic socioeconomic variables like occupation and income added. All of that was predetermined, but the thing that I was really excited about, and I'm going to talk about today, was the development of an expanded social determinants of health module, bringing it back to that social determinants language, right? It was the NAC and the NIA's clinical task force decided that we were indeed going to put together a work group and actually develop a brief, and brief was really operative here, module collecting whatever social determinants this group decided were the must-haves, constructs, individual items. So over about 6 or 7 months, 13 of us got together on a pretty regular basis, and we hashed this out. We came to a consensus and we made recommendations. And I just kind of want to go through that process really briefly with you because I know that a lot of you will have questions about what was included and what was not. So there were a couple of criteria that our group really used as a common ground to come back to and start from and be speaking the common language about. And those criteria in the selection were first, so we know from that CDC model of social determinants that I showed you, from the NIA Health Disparities Framework, that there are these multiple levels of data and analysis that are upstream of biomedical factors, of behavioral factors, right? And we wanted to be sure that we were selecting constructs, we were selecting ideas and concepts from across multiple levels. We also wanted to know that whatever we were selecting, whatever constructs, showed strong empirical associations with ADRD outcomes already, or with ADRD, dementia, risk factors, diagnosis, and care. We always, of course, have an eye to a more inclusive future for our ADRC cohorts and for the larger NAC cohorts. But we also wanted to make sure that there was already, we were selecting constructs where there already would be a pretty good distribution of the data, right? Where we were going to get some people at every level. So we focused on constructs where we expected that there would be variation already available to analyze the first time that the data was collected with our existing NAC cohort. Of course, we focused a little bit on availability of validated instrumentation. That was important. And finally, because there's been so many innovations with geocoded data, we did, in terms of looking not only at neighborhood level disadvantage, but also segregation, environmental contaminants, and so on, we wanted to make sure that we focused on lived experiences that we thought probably could not be easily surveyed through just linking participants with publicly available data sets. We really focused on things we thought we needed to survey. So I guess I just revealed the first construct that we decided on. I'm going to talk about this in terms of things that we have recommended. We are in the proofs stage of this after a lot of feedback, but nothing's really final until it's actually out there in the centers, right? So I'll use sort of if language here. From the environmental domain, we selected the need to look at transportation security. So this included basic questions about transportation access, household car ownership, consistent access to transportation. We know that changes in access to transportation, and particularly reliable transportation, can really have huge impact on the lives of older adults in terms of the resources they're able to access, in terms of the activities they're able to engage in. So we thought this was really important. And we also drew 4 additional items from a validated index, the Transportation Security Index, that got at smaller nuances of this, that our participants have indicated that they care about. So these are things like the restricted life space that can start to happen when transportation access becomes limited. Things like the time involved in using less efficient modes of transportation and what it can take away from other desirable activities. We also, oh, okay, I see. I made some, let me go back here. I moved some things around at some point. Apparently it's in an older version. I'll focus on financial stress next. This is kind of a sociocultural domain, right? And we know that there are big associations between financial insecurity and health of all kinds, including brain health. So here we focused on questions that look at either perceived satisfaction or stress arising from an individual's financial situation. We also asked about objective financial challenges, difficulty paying bills, difficulty paying for food or medications. And finally, and a lot of you probably have seen this ladder, we asked about subjective social status, because perceptions are really important in terms of how people feel and how it translates to themselves. We did also, I didn't have it on here, but we did also include childhood socioeconomic status as assessed by asking a little bit of in-depth information about parental educational attainment. So that's financial stress. Staying within that sociocultural, though it starts to span kind of a psychosocial domain, we thought it was really important to ask about social isolation and its protective, converse social connectedness. We figured that there would actually be pretty high interest in centers and their investigators, given that now social isolation has actually been established as a key modifiable contributor to global dementia burden. So we drew questions on social isolation from an established questionnaire that's been offered by the Rush ADC to its participants for a long time. We also ask about both strong and weak social ties, knowing that health benefits come from different domains. And finally, knowing that the community that we're living in actually can either facilitate or present a barrier to social connectedness. We also integrated some predetermined questions on home and environmental safety into this section of the questionnaire. Okay, I thought this was going to come next before, and now I'm glad to see it. We also focused a little bit on healthcare experiences, and it was really gratifying to see this come up in several talks earlier. So here we drew questions that we thought got at the idea that availability of healthcare is not necessarily accessibility of healthcare, nor is it quality of healthcare. So we asked a number of questions here, running the gamut from delays in seeking medical attention, difficulties filling prescriptions, difficulties following physician's advice, and access to insurance as well. Thinking about a lot of the really robust findings coming out of Dr. Lisa Barnes' group and now so many other groups on discrimination as a really important determinant of health in minoritized communities, we also integrated a number of the general discrimination questions that many of you have probably seen before, and a question about discrimination during healthcare in medical settings. We also, of course, ask people, as Dr. Williams and others have done, what axes of identity they feel is the target of the discrimination that they're facing, and what level of stress are people actually attaching to these experiences. We know that this differs by age, by cohort, and so on. How much time do I have? I'm good? Okay. All right, let's do the overview then, and then talk about next steps. There are a couple of details that probably folks in here, particularly those who have to coordinate visits, who have to actually run their centers, care about key details of administration of this new module. It's going to be mandatory only at the first UDS4 visit. Centers can opt in after that to administer it again at repeat visits. It's always nice to have access to time-varying exposures, right? And to study those and look at how transient effects are, but you don't have to. It's intended to be self-administered in persons who are at a cognitive status where they can fill it out themselves. This isn't designed to be filled out or completed by a proxy. And finally, in our preliminary testing, this isn't formally piloted, it's going to family and friends, it appears that it takes about 10 minutes, but of course there's tail ends to that distribution too, but about 10 minutes for most participants, looking at people of all ages taking it. That's not what I want to focus on though. I wanted to give you those details, but it's not the take home that I want to send you home with here. The take home is here, and this came up it came up in our feedback rounds with all of you, with the clinical task force and the other work groups. It definitely came up in our group as we were hashing this out. This module does not provide, it does not collect comprehensive social determinants of health. It's not enough on its own. It is missing things that all of us felt, and they weren't always the same things, but it's missing things that all of us felt were vital to include, and we just didn't have room. So the next step on that is to expand it, maybe center by center, right? The idea here is that our data protocols, to some extent, should represent communities and should include community partners who are served by the individual centers. So that means that we probably need to be considering, we do need to be considering, this spoiler, adding additional population salient, community-specific social determinant of health instrumentation or full modules. We should be designing these and adding them so that we're collecting information about, that we can provide sort of this module is designed to provide amazing, harmonized social determinants of health data across a really big cohort that is a jumping off step for investigators who want to do more, right? That's what we're trying to support with this module. So we're hoping that it can be used that way, but not everything needs to be harmonized, right? We serve individual populations that also came through in our work group meetings. When we're talking about what a population-specific or a community-salient module might look like, I'm going to encourage us to seek out community information and community partnership in designing it from the get-go, actually. I don't have a lot of time to talk about the Stress and Resilience or STRIDE study today, but I will say that it's always meant to be an adaptive protocol. At first, I was just adapting it to informal feedback that I was getting from participants. Eventually, when Dr. Gleason at the Wisconsin ADRC was able to build up cabs, I was actually able to work formally and in a funded way with tribal community partners to, first they helped me select the actual constructs that we would study, and then once we were funded, they picked specific instruments that they thought worked best for Indigenous elders in a tribally tailored social determinants module. I think this has enriched my science. I also think, since we're talking about enhancing participation, doing this kind of responsive research where it's a partnership that continues on and you're going back and forth all the time and you're actually, as a researcher, listening, I think it also has really helped me build relationships that'll be important for research going forward. I'm going to end there. I want to thank this work group. As you can see, there's a lot of amazing scholars who were on it, and many of them are in the audience today. For more information, feel free to contact me or my co-chair, Dr. Lisa Barnes, but I'm also here to answer questions afterwards. Thanks so much.